All right, welcome back. We're going to be dealing with tachycardias in this session of preparation. We've divided this topic into four subtopics: narrow and regular, narrow and irregular, wide and regular, and wide and irregular, because each four of these subtopics has its own internal logic and differential and are best dealt with in those subsets. So let's start with the simplest of the narrow and regular. That is sinus tachycardia. You'll notice first that there is a P that precedes each of the QRSs, and then there is a QRS after every P. That is the defining characteristics of sinus. If you put a calipers on, you would also notice that there is a little bit of variability in the rate. So there are just slight differences in spacing between various QRSs, and that often is due to breathing. So when a person takes a deeper breath, they stimulate the vagus nerve more, which in turn slows down the heart just a little bit. Could be movement, anxiety, or all these different kind of things. So it lacks the machine-like precision that you see with atrial flutter and with SVT. So what are the defining characteristics of sinus tachycardia? Again, the fundamental one is that there's an equal number of P's and QRSs. So there is a P before QRS and there's a QRS after every P. This should lead to two little squiggles between two adjacent QRSs. There should be a squiggle for the ST segment and then a squiggle for the P wave, although sometimes this can be difficult to appreciate as the heart rate starts speeding up and everything gets closer, more closely bunched together. Also, there is a maximum heart rate at which sinus tachycardia can go, and that rate is about 220 minus the age for men and about 210 minus the age for women. So if you see an 80-year-old lady who's going at 170, that is fundamentally unlikely to be sinus tachycardia because an average heart simply cannot go that fast while in sinus. And finally, there should be, even for very regular sinus tachycardias, there should be a little bit of variability. So for example, when a person takes a deeper breath, that stimulates the vagus nerve more, which slows down the heart a little bit. So it doesn't have the machine-like precision that atrial flutter and SVT do. The second option for narrow and regular, it's atrial flutter. Now, you will see here first that the rate is almost exactly 150 beats per minute. There is just about 2 squares between two adjacent QRSs. Second thing you'll notice is there is only the one squiggle between two adjacent QRSs, the ST segment. There is no P wave. And third is that it is regular with almost machine-like precision. In the previous example, it was a 2-to-1 flutter, which means that only every second of the atrial waves got conducted to the ventricle, and those can be a little bit tougher to see. If you have a higher grade flutter, so in this case it's 4-to-1, and only every fourth wave is conducted to the ventricle, it becomes much easier to see and appreciate the flutter waves. What atrial flutter is a reentry loop within the atria. And for the average sized human heart, the right atrium specifically is of such size that the electricity will go around it about 300 times a minute. However, we do have a break in the form of the AV node, which means that not every one of those impulses will get transmitted to the ventricles. And if a fixed percentage of that gets transmitted, then we'll have things like a flutter with 2-to-1 conduction at a rate of about 150. If every third impulse gets conducted, we'll get 3-to-1 conduction with a rate of about 100. And sometimes it's a variable percentage of beats that gets transmitted, in which case we'll have a flutter with variable conduction. So what is the clinical significance of atrial flutter? The systemic effects are very much like atrial fibrillation due to the lack of well-organized atrial contractions. There is probably a bit less risk of stroke than with atrial fibrillation. In most of the studies, they get clumped together, but are not quite the same thing. It is often more difficult to convert with medications than atrial fibrillation is. So often it will require electricity, And as mentioned, the 1 to 2 conduction, which is probably the most common one, will usually give you a rate of about 150. Now, this is again dependent on the size of the atrium. So if you do have somebody with a very large right atrium due to pulmonary hypertension, then the actual atrial flutter rate might be less than 150. And it's very, very regular, and there is only the one squiggle between the two adjacent QRSs. The final option for the narrow and regular is an SVT. Now, what you can appreciate here is that it's going quite fast. In this case, it's going at a rate of about 180 or so faster than flutter and faster than most people would be able to sustain in a sinus tachycardia. It is very regular with machine-like precision, and also there is only the one squiggle between the QRSs. Now, SVT is actually a bit of a misnomer because anything that's fast and it's not ventricular tachycardia is an SVT. So technically atrial fibrillation, flutter, and sinus tachycardia are all SVTs, but what we actually mean when we say SVT are two rhythms. One is called AV nodal reentry tachycardia, which simply means that some people have two conducting pathways within their AV node, and what can happen is the electricity goes down the one pathway, the alpha, and then gets conducted retrograde upwards through the second pathway, the beta, and that sets up a little reentry circular loop within the AV node itself. The second one is the AVRT, the AV reciprocating tachycardia, and what that is an accessory pathway, an extra wire, kind of like Wolff-Parkinson-White, except Wolff-Parkinson-White, the wire conducts from the top downwards, and in this case the wire conducts from the bottom towards the top. So what can happen is the electricity can go down through the usual pathway and then get picked up by the extra wire, conducted back to the top to the SA node or the atrium, and then shot back down, and now we have a re-entry loop within this whole system that involves the SA node, the atria, the AV node, the ventricle, and the accessory pathway. Luckily, we don't have to really distinguish between these two entities because they behave clinically very similar and they respond to the same treatment. And SVT in general is harmless, although most people feel it and can get quite symptomatic with it. Rarely, if they have a weak heart and coronary artery disease, just the tachycardia of it can be damaging to the heart, but in general, SVT does not lead to any damage. Traditionally, SVTs have been dealt with either vagal maneuvers or adenosine, which can be quite traumatic to give to people. It does make them feel awful. There is new research that shows that deltazem given at 10 to 15 milligrams in a mini bag over 10 minutes is essentially 100% effective in resolving it without any pain, discomfort, or effort on the patient's part. And that probably should be our preferred method of doing it. So this is our narrow and regular summary. The options are sinus tachycardia versus an SVT versus atrial flutter. How do we diagnose those? Well, remember that sinus tachycardia can only go at a certain rate that's dependent on age and sex. We can count the squiggles between QRSs. Sinus will have 2, although it can sometimes be hard to count those 2. SVT and flutter will only have the 1, and then we'll look for slight variability that sinus tachycardia has, but flutter and SVT do not. And if we're ever in doubt and we truly cannot decide, the safest and the most efficacious thing to do is to attach the ECG leads on and then give the person 6 milligrams of adenosine and see what happens. If they're in sinus, they will slow down and it should be easier to count those squiggles and appreciate the P waves. If it's SVT, they will usually convert. And if it's a flutter, they will convert from a 2-to-1 flutter, which can be hard to diagnose, to a 3-to-1 or 4-to-1 flutter, which, as we saw, is much easier to diagnose because you will see those multiples of sawtooth waves between the adjacent QRSs. Moving on to narrow and irregular, we start with the simplest one, which is sinus arrhythmia. Again, if you look at this EKG, you'll see there is an equal number of P's in the QRSs. There is P before QRS and a QRS after every P. But you'll notice there is significant variability here as we go along the rhythm strip. At this point in time, it bears remembering that being regular is not in fact a diagnostic criterion for sinus rhythm. It is just commonly regular, but a significant portion of people, especially young people, especially young women, will have somewhat irregular sinus beats. Does this matter? No, not at all. It is entirely harmless. However, some people do feel those irregularities as slight palpitations, and it could be symptomatic, and in that case, a very low dose of a beta blocker might be helpful to reduce those symptoms. Generally, as you get older, this wandering baseline sorts itself out as the electrical system learns to become more regular. The second thing that can happen that can produce some irregularity is PACs, which is premature atrial contractions. So if you see closely at a rhythm strip here in lead 2, you will see that the second beat kind of comes prematurely. So the ST segment and the P wave are very close together, and afterwards everything gets more regular for a while. So what's happening here is just the atria or in the SA node firing off an extra beat before their time, but sufficiently after the previous beat that the heart is not refractory and it will conduct that extra beat. Just like sinus arrhythmia, it really doesn't matter. It's quite common. It is entirely harmless, although some people will feel those extra beats again as palpitations, and again a very low dose of beta blockers might be beneficial to reduce those symptoms. Then they might have PVCs, which is the bottom of the heart shooting off at sometimes regular, sometimes irregular intervals. Remember in bradycardia we covered bigeminy, which is somebody who is firing off PVCs after every regular QRS. In this case, there is no such thing. It is just occasional, and again, this is harmless, but some people will feel it. Now, I will draw attention to two of the characteristics that really identify these PVCs as coming from the ventricle. First is, let's look at their 2D axis, and what you will see that it's a little bit tough to assess. Lead 1 is negative, which means it's going rightwards. Lead 2 is very positive, which means it's going down and to the right. And if you look at lead 3, it is the most positive lead. So electricity is going down and towards the right, which is a very unusual axis, right? We only said we should see that if there is right ventricular hypertrophy, but if you look at the normal QRSs, there is no such thing. So what's happening here is these ventricular extra beats are coming from where the majority of the muscle mass in the heart is, which is on the left. So a lot of the times, ventricular beats will have a right deviated axis. That's actually one of the most specific things that identifies a wide QRS as coming from the ventricle. The second thing you can see here is when you look at the precordial leads. Now again, we said that if we had a right dominant leads V1 and V2 should be strongly positive and the rest strongly negative. If it's left dominant, leads V5 and V6 should be strongly positive and the rest should be negative to various degrees. But here what you see is that all the leads are strongly positive. So this only happens in ventricular origin beats. What's happening here is the electricity is coming from the left side of the heart, as we discussed previously, but it's also coming from the left and posterior wall of the heart, so from the very back of the heart. So from that point onwards, this wave of electricity spreads anteriorly towards all the precordial leads. So if you see all the precordial leads being entirely positive or entirely negative, if the origin of the beat is coming from the front of the heart, then again, you can be certain that this is a ventricular origin beat. So what do we do with PVCs? Well, it depends on the context. If they're within 48 to 72 hours of an acute MI, they can be dangerous, and in fact, they predispose people to developing ventricular tachycardia, so we have to watch them closely and sometimes suppress them. If they're chronic, they tend to be harmless, although again, just like a lot of these little irregularities, they could be symptomatic for some people. If they're every second beat is a PVC, we discussed previously it's bigeminy, but it's still not going to harm an average person. Again, some people do feel these, so a low dose beta blocker might be effective in reducing the symptomatology. And this is bigeminy, as we discussed in the bradycardia. Every second beat is a PVC. Finally, we have atrial fibrillation. You will notice it is quite fast, and also that it is very irregular. So it is irregularly irregular. You will also notice there is a little bit of oscillation around the baseline, so almost like little P waves, but they all look slightly different from each other, and are not big enough to be Ps, and are not in a fixed relationship to the QRSs. And also the QRSs are of slightly different height and morphology and magnitude. And what's happening here is different pieces of the atria have now become independent pacemakers and are all firing independently of each other, each one depolarizing parts of the atrium. So that's the little variability around the baseline, and then each in turn depolarizing the ventricles in slightly different fashion, which accounts for the variability of both the rate and the morphology of the QRSs. Now, what do we do with rapid atrial fibrillation? Well, if the person is unstable, and that would be signs of ischemia to the brain or to the heart, so low blood pressure plus decrease in mentation or a change in mentation, and a low blood pressure plus chest pains presumed of ischemic nature or ischemic equivalent shortness of breath, then we consider that person unstable and we would cardiovert them. Now, this is not an easy decision to make, because when you do cardiovert somebody, if you don't know how long they've been at it, you're essentially giving them about a year's worth of risk of stroke in that one cardioversion if they have happened to be in atrial fibrillation for a substantial period of time. So it shouldn't be a trigger that's pulled lightly. Now, if the person is stable and we think that this has been going on for more than 48 hours, we should do rate control. And there is a number of studies, but the balance of evidence is that diltiazem is more effective than metoprolol, usually given as an IV dose and then supplemented with an oral dose as well. And magnesium can be a useful adjunct in achieving rate control. Now, there is some debate over the 48 hours rule. There is one large population-based study from Scandinavia that showed that you can start developing clots within 12 hours of onset of acute atrial fibrillation. So it might be questionable whether it's worthwhile rhythm controlling stable people who have been at it for more than 48 hours, but certainly if they have been at it for less than 12 hours, again, potentially up to 48 hours, even if they're stable, we can consider doing rhythm control. The first choice would be procainamide, 1 gram given over 1 hour, and this is effective 55% of the time. And if that doesn't work, then we can proceed with electrical cardioversion. Amiodarone is another medication that can do rhythm control, but it takes an average of about 6 hours, so that makes it less useful. So that basically is the narrow and irregular summary. Atrial fibrillation versus the various sinus variants like sinus arrhythmia, PACs, PVCs, bigeminy, and so on. All the sinus variants are essentially harmless, and atrial fibrillation we discussed how to treat. So the main trick is recognizing atrial fibrillation as such. Now we're moving on to the wide rhythm. So we'll start with wide and regular, and the essential differential is for the regular part is no different than with the narrows. So it's SVT versus flutter versus sinus tachycardia. But because it's wide, we have to add a few more things. And the essential job here is to separate the left bundle branch block, which will induce wide QRSs in all the leads versus ventricular tachycardia. If you look at the American Heart Association position statements and the ACLS, they will say that of the two, ventricular tachycardia is by far more likely at about 80 to 20% ratio. I would like to quibble with that a bit because all that literature was taken from the coronary care units and the intensive care units. So obviously in that very specific pre-selected populations, VTs are going to be more common just at a level of primary care, given the number of people that have pre-existing left bundle branch blocks. I would think that LBBs are in fact the more common ones. Now, that is the essential job, the left bundle versus VTs, and we'll spend some time figuring that out. And the third and less common cause would be toxic causes. So things that block the sodium-potassium system, most of the time the sodium system. So again, things like procainamide, if somebody's on too much of that, or if they've taken things like tricyclics, which also have partial sodium channel blockade. And that becomes more of a play if you see wide and regular that's not super fast. So usually they're not going at 160 and 180. They tend to be very wide, and they tend to have either weird morphology or weird axis. So this is the first case. This is just somebody who has a sinus tachycardia, or just about. His heart rate is 95, so he's just in the border. And has a left bundle. How do we know he has a left bundle? Well, he has all the cardinal features of it. It's a left dominant axis in both 2D and 3D. We have wide QRS. We have the notching, especially visible in 1 and AVL. We have QRS to ST discordance, and we have the asymmetrical QRSs in the precordial lead. So for example, look at lead V1. After the slight upwards deflection, it goes almost straight down and then comes back at an angle. So what do we do when there is a left bundle? The main thing with it is to recognize it and then generally ignore it. In a previous iteration of ACLS, the new left bundle in the presence of chest pain was considered a STEMI equivalent. After more research, we found that maybe about 1 in 6 of what was considered new left bundle with chest pain actually turned out to have an acute heart attack. So now we dig deeper, we do our blood work, we do our troponins, and we will discuss in the ST segment some criteria by which you can in fact diagnose ischemia in the presence of the left bundle, but it's not an automatic STEMI alert anymore. This is somebody who has an SVT with a left bundle. Okay, how do we know it's SVT? Well, it is quite fast. It is machine-like regular, and there is only the one squiggle between the QRSs, but it isn't quite going at 150. It's going at about 170, 180. So again, too fast for most people to be in sinus, and not at 150 that atrial flutter likes to go at. It has all the criteria of a left bundle: left dominant axis, wide QRS, the notching in 1 and AVL, the QRS to ST discordance, and the asymmetrical QRSs in the precordial leads. So it's faster and more regular than sinus tachycardia. It has the left bundle morphology, and it probably is that. The main problem with this is that it can be hard to distinguish from ventricular tachycardia. In this particular case, I was quite certain about this patient and I proceeded to treat him as an SVT. However, if you truly are uncertain, the safest thing to do would be to assume it is ventricular tachycardia and treat it as such, and we will talk about treatment in a minute. So this is finally an example of ventricular tachycardia. So it's wide, it's fast, and it's regular. Let's go over how it differs from a left bundle. So first of all, let's look at the axis. Lead 1 is negative, which means electricity is going rightwards. Comparing lead 2 to AVL, lead 2 is strongly negative, which suggests the electricity is going up, And when we look at AVL, there is in fact an upwards component. In fact, AVL is isoelectric, which means that electricity is going perpendicular to it, so either right and up or left and down. Left and down is where lead 2 looks towards, and lead 2 is strongly negative, so it's not that. So electricity is going right and up. It's lead AVR that looks right and up, so let's look at lead AVR, and we see that it is strongly positive. So this is extreme right axis deviation. What's happening here is that the origin of this ventricular beat is at a very apex, at a very tip of the heart, the very bottom of the heart. And from that point, it's spreading upwards and rightwards, kind of backwards from the usual fashion, how the electricity normally goes. So when you do see this extreme right axis deviation, electricity going right and up, you can be certain that it is coming from the ventricle, because left bundles should always have a left dominant axis. Also, you see that there is no notching in 1 and AVL, not of the type that we're accustomed to, and the morphology of the precordial leads look different. You don't have that kind of asymmetrical QRS that goes straight down in the anterior precordial leads. In fact, these precordial leads are going up, so it has a right axis deviation in the precordium too. Finally, if we look at lead 2, we see that kind of almost like shark's teeth, right? So it's somewhat symmetrical, and they go down at an angle and they come back at an angle, and that's just an experiential way in which you can learn to recognize ventricular tachycardia. But the main message from this slide is that if you see extreme right axis deviation in the presence of a wide QRS, it is coming from the ventricle. The second way that you can tell if the beat is coming from the ventricle is all the precordial leads pointing in the same direction. So let's look at this other example of ventricular tachycardia. If you look at the 2D leads, you might be fooled into thinking this is a left bundle. Lead 1 is positive, so electricity is going towards the left. AVL is positive, so it's going left and up, so that's left dominant. That's okay. But when you look at the precordial leads, you see that all the leads, V1, V2, V3, V4, V5, V6, they are all pointing upwards, which again means that a source of electricity is the very posterior aspect of the heart, and from there the wave of electricity is spreading forwards towards all the precordial leads. Why do VTs happen? There are basically two main reasons. One is acutely in an MI. You have a damaged or a stretched myocyte that normally beats at 30 to 40 beats per minute, as we discussed in the third-degree AV block. Well, now they're damaged, and in their damage, they get a little bit irrational, and they can start beating much faster at a rates of 200 and 300s and so forth. The second reason is that person has had a previous MI and has developed a scar. Now, electricity cannot go through scar tissue, so what happens is electricity goes around the scar, and occasionally it catches its own tail, and now you have a re-entry loop within the ventricle itself, shooting off electricity in all directions. This commonly happens with people who have a lot of scar tissue, which is to say they have ischemic cardiomyopathy with an ejection fraction of less than 35, and it's one of the most common indications for needing an implantable cardiodefibrillator. So why do we care about VT? Because it can be quite deadly. Again, there are two easy clues. If you see extreme right axis deviation, right and up, or if you see what's called precordial concordance, which is all the precordial leads point up or they all point down, then you can be sure it's VT. Now, both of these signs are specific but not sensitive, which means not all VTs will have them, but only VTs will have them. If you're lacking these two criteria and you're unsure, if the patient is unstable, just go ahead and cardiovert them. And if they are stable, as even some VTs are, then give them a gram of procainamide over 1 hour, and hopefully it will resolve. So when we're talking about wide and regular tachycardias, we really have two jobs. The first one is to see if the morphology shows all the signs, and we really do need all the criteria of a left bundle branch block. And if it is, then we can pretty much ignore it and just look what the underlying rhythm is, whether it's sinus tachycardia or flutter or SVT. And then on the other hand, we want to see if this is a ventricular tachycardia. And again, we can use those two criteria, the extreme right axis deviation and then the precordial concordance. And if we do see either of those criteria or both, then this rhythm is guaranteed or pretty much guaranteed to be a ventricular tachycardia. And then in between, there's going to be rhythms that we really can't decide, and the safe option would be to assume that they are VT. If it is VT and the patient is unstable, we want to do a synchronous cardioversion, and if they are stable, then we're going to give him a gram of procainamide over an hour. I just wanted to point one last thing, is that if you have a person with a pacemaker, pacemakers always produced a wide rhythm. Why? Because the pacemaker wire attaches itself somewhere in the muscle, and then from there the electricity spreads cell to cell, not using the normal His-Purkinje system. However, you should be able to see the vertical pacer spike before each of the wide QRSs, and occasionally those rhythms can be fast depending on the settings for the pacemakers and how fast it will allow the heart to go. The trick is to recognize those vertical pacer spikes and then pretty much to ignore, because it can be very tough to say what else is going on with a heart if it is being externally paced. So this is our summary for the wide and irregular. The main task is to distinguish the left bundles, which in my experience in primary care are far more common than VTs, and we don't always want to treat these people aggressively, but we do want to separate the benign left bundles from the more deadly ventricular tachycardias. To do so, we have to know our left bundle branch block criteria very well, and we need to know that if we see right axis deviation or precordial concordance, which means all the precordial leads pointing in the same direction, we know that this is ventricular tachycardia. And if we truly cannot decide between those two options, we will assume that it's VT. Stable VT gets treated with cardioversion or procainamide, and unstable gets treated with emergent cardioversion. Going on to wide and irregular. Again, remember, for the irregular ones, the main decision is atrial fibrillation versus something else. So probably the commonest one, certainly in my emerge experience, has been atrial fibrillation with an underlying left bundle branch block. Again, if you look at this rhythm, it has all the hallmarks of atrial fibrillation. It's irregularly irregular. There is all those little oscillations around the baseline. There is different morphologies and amplitudes of the QRSs, and then it has the four features of the left bundle branch block. Again, the treatment of AFib with a left bundle is to pretty much ignore the left bundle and treat it like you would the underlying atrial fibrillation, but you have to be able to recognize it as such to do so. This is WPW or Wolff-Parkinson-White. It's probably best appreciated in leads V2 and V3. So what you can look at is that we have a P wave and then a very short PR interval, and then we have what's called a delta wave. In actual morphology, what it is, it's a beginning of a wide QRS, and then the QRS suddenly narrows. Now this is why this happens. So people with Wolff-Parkinson-White, they have an extra wire in the heart that conducts downwards from the SA node region all the way into the ventricle, and it does not attach into the His-Purkinje system in the ventricle, but just in some random myocyte. So what happens first is a signal originates in the SA node, and it is transmitted through both the AV node and the accessory pathway. Now remember that the AV node is a block in the system. It slows down conduction, so it's going to take time for that pathway to conduct its signal down using the AV node and then the His-Purkinje system. But there is no similar break in the system on the accessory pathway in the extra wire. So the impulse reaches the ventricle very, very quickly, and therefore you have a very short PR interval. But because it doesn't attach into the His-Purkinje fiber, it attaches into some random myocyte, when it does reach the ventricle, it starts to depolarize the ventricle using cell-to-cell conduction, which is essentially wide. Now, if it continued that way, you would have a fully wide QRS, but remember that there was a signal that was sent through the AV node, and at about 120 milliseconds, it manages to go through the AV node and then rapidly depolarizes the rest of the ventricle using the His-Purkinje system. So that's why you have the three features of WPW: the short PR interval, the beginning of a wide QRS, and then a narrow QRS as the rest of the ventricle depolarizes using the standard means. However, about 30% of these folks will develop atrial fibrillation as well. This is a problem. Atrial fibrillation, if you remember, is a whole bunch of ectopic pacemakers in the atria, little pieces of atria just firing off randomly, and they do so very fast. The rates can be 300 all the way up to 600. This person has an extra wire. Normally, all the impulses get conducted in the AV node. The AV node acts as a brake in the system and will only conduct a certain percentage of these extra beats, therefore maintaining ventricular rate at somewhat reasonable states, like maybe 120, 140, even 180, but not 300 or 600. But these folks with WPW, they have an extra wire that can bypass the AV nodal system. Therefore, all these ectopic beats can conducted on a one-to-one basis from the atria to the ventricle. This is how that looks like. If it looks like dog's breakfast, it's probably WPW with AFib. What you can see that it's very rapid. It has different morphologies. It's somewhat irregular, and occasionally you see escape beats that look narrow. Those are the beats that gets transmitted down the usual way, down the AV node and then His-Purkinje fibers, while all the other beats are going down the accessory pathway. This particular rhythm is the main reason why we don't generally want to give AV nodal blocking medications like adenosine and metoprolol and diltiazem to people with wide QRS tachycardias. Because if we do so here, we will block off the usual pathway of transmission and force all the transmission to go down the accessory pathway where, as we mentioned, there is no break. Now you will have ventricular rate of 300 to 600, which will rapidly lead to fibrillation and death. So to summarize, AFib with WPW is luckily rare. It looks super messy, again, as I like to call it, dog's breakfast. When you do see this widely irregular and messy looking beats, look for escape beats or normal QRSs among the weird wide ones. And what these people need is cardioversion. If they're really stable, which should be rare, you can try to give them procainamide a gram over an hour. But for most, we should apply electricity. And these are the patients that if we do give them AV nodal blockers like diltiazem or metoprolol or adenosine, we will likely kill them. So let's not do that. The final possibility in the wide and irregular is torsades, which is polymorphic VT, which is also a very lethal rhythm. Wide usually happens is if you have a very prolonged QT interval, which is the main reason why we want to measure those, is the next beat can come down and try to depolarize the ventricle while it's still repolarizing. The resulting collision of currents will set the heart in a tizzy and usually induce this polymorphic ventricular tachycardia. It's called polymorphic because unlike those previous examples of VTs, you can see how there is a difference in the amplitude and somewhat in the orientations of the VT beats. The other possibility, or the other group of people who will sometimes go into torsades, is people who have very low magnesium, which can precipitate a similar chain of events. So, how do these people look like? They're VTs. They look like amplitude modulated radio waves. They oscillate in amplitude. As we mentioned, they're caused by long QTs and or low magnesium. They require cardioversion, and in the rare cases they're stable. We can give them 2 grams of magnesium IV over 20 minutes, or procainamide 1 gram over 20 minutes to an hour. So in summary, wide and irregular can be summarized as atrial fibrillation with left bundle, which we generally treat as just ordinary atrial fibrillation. The trick is recognizing it, versus bad things like Wolff-Parkinson-White with AFib or polymorphic VT. Those are both lethal rhythms, and what we want to do with those is generally cardiovert them, and in the rare cases they're stable, we can give them procainamide, and in case of polymorphic VT, we can give them magnesium. Thanks for listening, and we'll see you in the primer number 4, the ST segment changes.